Brandy Mack, and this is my podcast. I can't even remember the name of it. No, for real. I'm trying to, because I changed it. It's, what is it? I'll add that later. Anyways, so we have today Dr. Taylor Nichols with us. Those who don't know, is on TikTok. He is a certified addiction physician and ER. He's worked in ER also, and him and I have had the opportunity to really interact a bunch through social media, and I'm so happy he agreed to do this. I went on his podcast with Macaulay Sexton a week ago, 2 weeks ago, and I had a bunch of questions I wanted to ask this man. So, all right, welcome, Taylor. And I guess we'll start with introduce yourself and kind of what led you into from ER to also certifying in addiction medicine.
Thanks so much for having me, Brandy. I really appreciate it. I started out in medical school really just wanting to. I liked sort of general medicine, family practice, and then I really thrived in the high acuity setting in the emergency department. And I liked that I still got to see and do everything, sort of broadly see everyone of any age. And it really involved a little bit of every sort of field of medicine. And you got to like be in the middle of the action and save lives and treat everyone who came through the door. And that's really the ethos of emergency medicine is there's kind of a motto: anyone, anything, anytime. We're open 24/7, 365. We'll see anyone regardless of their ability to pay. We have a literal mandate called EMTALA where we have to see everyone who comes through the door. And I love that. We wear that as a badge of honor, right? And so that sort of like mentality really attracted me. I wanted to be able to do everything for everyone. And I did my emergency medicine residency after medical school at UCSF in San Francisco General Hospital. So I did 4 years there. I moved and worked in both an academic setting and a rural emergency department. And then I did a fellowship in health policy and advocacy because I've been in health policy and advocacy spaces for a long time. And I wanted to sort of strengthen my sort of skills and expertise there. But one of the things that as I was doing all this, I kept coming back to was seeing that the medical system, the healthcare system, one, was broken. And that was sort of where my advocacy stemmed from, is wanting to improve access and improve care for patients. And then seeing that the medical system was causing harm and perpetuating stigma against people who use drugs. And I was working, like I said, San Francisco General Hospital is a county hospital. It's the only county hospital in San Francisco. And so that was our target patient population. Those were our, people who like sort of became your regular friends of the emergency department, right? That was kind of what we joked. And they did. Like when you had patients who came in kind of every day and you didn't see them for a while, people would be like, "Oh, hey, did anybody go check on Tim or whatever?" And so I held this very negative view of drugs and the people who use them, coming from a place of having a parent who has a substance use disorder and being raised in sort of the abstinence only 12-step AA kind of mindset. That was how I viewed it. And then I recognized that maybe I was wrong. And if we were causing harm to them, then the only reasonable answer to that was harm reduction. It was like, let's reduce the harm to people who are using drugs, to people who are unhoused and coming through the door, who are like our regular patients. And so my mindset really started to shift while I was doing that. And then I had experiences working both in rural settings and in sort of my health policy and advocacy work, where I was seeing that sort of only amplified. And I was having experiences working directly with patients who were being harmed. And so I felt like, all right, I should start doing work to address this. And I'm very fortunate that I had a friend who is also in emergency medicine who worked in a harm reduction based clinic. And at one point we were having this exact conversation, and I was talking about how I was really frustrated by seeing this harm perpetuated. And obviously him being somebody who's understanding, who works in this clinic. And he said, why don't you just come with me to clinic? Like, you will like it, and you're interested in this stuff. And so I told him that my literal words were, I went into emergency medicine so I never had to work a day in clinic in my life. And he laughed at me. He said, just come, like, you will appreciate it, because this will resonate with you. And I walked in, and that very first day I sort of sat with him and shadowed him. And there were all these patients who expressed nothing but love for what they've experienced, and for him and his work, and for the founder of the clinic, who started the clinic now like 11 years ago. And it was so amazing for me to see a space where people felt that empathy and that love and respect demonstrated towards them, and that you're taking a already marginalized population who is deeply stigmatized, who felt incredibly comfortable with this person who's, one of my best friends in the world. And he's, literally after my first day, I was like, I'm in, I'm done. I'm going to do this. And now I actually have his job. Like, he gave me his job because that was what I decided, one of the things I wanted to do. And so I leveraged that to then pursue a board certification. You obtain enough clinical hours to qualify for the American Board of Preventative Medicine, which administers the board certification exam in addiction medicine. And I'd worked on some other harm reduction based projects that also helped me qualify. I helped I previously was working at Oregon Health Sciences University, and helped them start their buprenorphine initiation pathway in the emergency department. Because that was something that we did where I trained, right, in San Francisco General, where we had a lot of people who at that time, there was still heroin, and we were getting people, stabilized off heroin and into treatment. And we had a bridge clinic, follow-up clinic. And that was what I knew. And so when I started working at OHSU, I did that. And so between my experience in an addiction medicine, harm reduction focused clinic, and working at, OHSU, and in working just in the emergency department, and seeing how people were treated, and hearing how other people talked about people who use drugs, that really like motivated me, like, all right, I'm going to go get board certified in this. And it's something that I want to pursue more actively in my career. And so that's sort of how I landed here.
So, as you know, I did I was an ER
Yeah.
nurse, and I did it for 5 years. And I actually went to the ER because I just wanted to learn how to start IVs. That was honestly why, because I was like, I do not want to be in the ER. I was ICU. Like, that's what we do. But I ended up loving the ER, and that we actually had like a psych unit, pediatric and adult. So many times we would board psych patients,
Yes.
and then they also had a detox center. So
Mm-hmm.
we would end up, helping, move those individuals through to get into the detox program. And so I was interacting with those individuals, but I still had stigmatized views, like I've talked about, until, it hit home, and my daughter was an IV fentanyl user. So, but I'm curious. So you still work in emergency medicine?
Yeah. Yeah, I
Is
do both.
I want to ask this as a nurse. Do you, because I know you hear it being a
Yeah.
physician, when people say things, do you find yourself correcting them to nurses? Do you
Oh,
address it?
absolutely.
Yeah.
Yeah, and I like to approach it as there's always an opportunity to learn. I learned from being in the emergency department, and I use it as an opportunity to teach. And also, I happen to work in an academic institution where we are in a mindset of being open to learning and working with trainees, right? And so I know that when I was a trainee, I did not get this right. And so I know that I was open to learning, and that had I had an attending or a mentor who really guided me in that, I probably would have gotten here faster. Um, and so I try to be that for the residents that I work with, the med students that I work with. but yeah, I mean, I definitely hear it. I hear it from other providers. I hear it from um, from the trainees, and it's an opportunity for a discussion.
Mhm.
Um, and I think there are ways to approach that can be well received.
Mhm.
That and it may not always be, but I still want to make sure that, in the end, my message is always respect for patient autonomy, and people who use drugs also deserve respect for their autonomy, including in using drugs. And so, that is it is essentially the core principle of harm reduction, is like respect for the autonomy of people who use drugs.
Mhm.
And in my mind, it's like we're giving people drugs all the time. Like,
Mhm.
we use IV fentanyl for treatment in the emergency department, and then you have people who are using from an unsafe illicit supply, and then for some reason, like, that is viewed negatively. It's like, well,
Mhm.
why is one drug better than the other? Like, safety, sure, I get that. So then maybe people should be allowed to, like, have access to a safe supply so
Mhm.
that they're not, like, dying, maybe. Um,
Yeah,
so
no,
I
I have actually an interesting story. Is and I discovered this reading the chart of one of my patients that I had that actually had something pretty catastrophic, like a massive bleed,
Mhm,
brain bleed, and
mhm,
reading their initial admission through the ER at a different facility. They were ignored. They were actually sent
mhm,
home because they had nausea, vomiting,
mhm,
okay, which those who don't know, that's very common. If you have a bleed in the head, you have pressure and people get nauseous. And because she was also a chronic pain patient,
mhm.
she had extended release like meds, and they ended up they literally documented that they told her they were not going to give her anything additional
Yeah.
on
Oh,
top of her
God.
chronic pain, and which is not appropriate. And they sent her home with like Zofran, and and she had gastritis, and then she came back in because she was severely altered, and they
Yeah.
finally scanned her head and found she had a bleed. And that's a perfect example where it's
Yeah.
just the stigmatized view. And this woman, I mean, she had diagnosis
Yeah.
that why she was on chronic pain,
Right.
and and she was literally her head was killing her. That's
Right.
why, and she couldn't express it appropriately. And it was, well, your stomach isn't hurting that bad, and that's, it's ridiculous.
Well, and this is why I talk about the fact that the stigma against drugs and people who use them is harming people who have chronic pain and people who use drugs, who use prescribed drugs, prescribed safe opioids. Um, and it's weaponized against them, and they'll say, oh, well, you're just in withdrawal, or you're just, or people who have chronic pain can also have acute pain, and it's like, well, you already have opioids. It's like, well, those opioids get me
you
to baseline, like, that's
you
how
keep
I
those
function.
you keep
Yeah.
those going, and you add, like, that's
Right. And so when I work with people, when I work with residents or nurses, and they're like, "Oh, you're giving this person more opioids?" Like, yeah, like their functional baseline is at whatever it is, right? Whatever they're already taking. So that's like you or me. Like, we're at a functional baseline, and they need more treatment, right? Like, their pain meds that they already are using aren't going to help them with their acute pain. It's for their chronic pain. And same thing with people who are injecting fentanyl. If they're like, have a 2 gram a day fentanyl use, then we need to literally just get to their threshold of where their opioid receptors are in terms of dependency,
Mhm.
and then go above that because they're having pain. And that's going to be an uncomfortable number for a lot of people, but it's like, that's literally how physiology works,
Mhm.
that you have ramped up your opioid receptors, you have more to occupy.
which is why we count respirations.
Right.
We monitor vitals. And I have had to bring patients from a floor or even a PCU over because they're like, this person, we don't know what's going on with them. And I find out, they have substance use disorder. And I'm like, you're not treating. They're withdrawing. That's what's wrong with them. They're like miserable and they're withdrawing. And I bring them over and you start giving them what they can until you get symptoms under control and playing catch up. I know to that. It's challenging. And but it's amazing to me the amount of providers that do not understand even just continuing baseline chronic pain meds. They'll go from having someone on extended release to they're given 1 milligram of morphine. They completely cut off their chronic pain and they put these people in withdrawal. It's ridiculous. It's really a lack of understanding.
Yeah. And so I work on an inpatient addiction medicine consult service. And so we get a lot of these especially more complex patients who have, say, chronic pain and opioid use disorder. And we're trying to manage them. And I'm like, you guys just aren't going high enough. Like they're like, but we're already at whatever X number. We're on oxy, 5s every 3 hours. And I'm like, I'm talking 15 to 30. Like you got to go higher because they're using a lot of a highly potent substance on the street. Like we need to meet that demand there. That's why they're having pain. It's just, there is a deeply stigmatized view held within society and it's only reinforced further within healthcare by the regulations and restrictions that we're faced with and by the educational system that is now pushing strongly against opioids for pain management. And so if you were a person who already came in with stigma, which most people are, it's only going to be reinforced by the fact that you have to deal with all of the regulations against opioid use and the DEA potentially cracking down on you.
And something like I when my daughter and I discovered her use and my views really kind of started to change from interacting with, so many people who are in recovery is like, how is it hurting you to give them pain meds?
It's not.
You know what? It's not. If anything, they're going to, be a little more nice. They're going to be nicer, through it. You're going to have a patient you can tolerate because it is a difficult population. And I'm very honest about that because they come in already jaded by the healthcare system.
Yeah.
And
understandably
which
so,
is
by the way.
Understandable. And so they come in with this jaded attitude and they're already on the defensive, right? And so my daughter, classic, she's a fucking bitch. Like, I mean, she'll even admit it. She'll say that, like, she had stigmatized views, but when she would have those caregivers that really treated her like a person, she would relax and appreciate that and be kinder to them. And that's why I was like, why are you so mad? Like physicians, though, I get it because you have this crackdown from the DEA, and a lot of physicians, I know some, they would prescribe, they get pulled in by the hospital and ridiculed. You're prescribing, you have the highest opioid prescribing rate and all this stuff.
And they track you against your colleagues.
Yeah, no, but they had empathy. Like like the one physician I worked with, like he would get pulled in and lectured about this. And that's what makes physicians so scared to prescribe. And it's not right. Especially we're dealing with emergencies, acute pain. And like, come on.
Yeah.
And it's really baffling to me.
Yeah. And this is not to say that there aren't multiple modalities of treatment, right? And we should always try to use multiple modalities of treatment to try to control somebody's pain, because opioids aren't necessarily treating the root cause if there's a root cause that is treatable. And there are ways that we can use adjuncts, and there are other options that people don't know about. IV lidocaine for renal colic, for example, that's
really?
not regularly practiced, but I
didn't know about that.
It is evidence based. So somebody with a kidney stone, you can give Toradol and IV lidocaine. It has to be over time. It has to be hung, but you can do that. And granted, that is a severe pain causing etiology. So you can also and should also probably give them opioids, especially if that initial, right? We don't always have beds available. We don't always have time. We can't necessarily like give meds right away, but we can give like a Toradol shot in triage, give, or give Tylenol. Like we can do those things up front. And when that doesn't work, because it doesn't always work, if they're still having pain, like give them opioids because that is severely painful. But yeah, we can try all these other adjunctive things in conjunction with using opioids. And then there's always the like trying to sort out what the root cause is and addressing that because that's going to be the most effective treatment overall. So it's not to say that that's the only option we have, but it is something we should use every tool in our tool chest to try and treat people appropriately and meet them where they are in an ethical way. And so I try really hard to emphasize that to other clinicians too.
This brings me into actually one of the questions I even had written down to ask you about was I had noticed even surgeons or like anesthesiologists
Mm-hmm.
when people are on MAT, so like Suboxone,
Mm-hmm.
and they have surgery scheduled and they go in and they have no plan in place for how they're going to manage this patient's pain. And it's is I have heard of ketamine being used for it, and then otherwise, you need to be giving high doses of fentanyl IV. Like that's my
Yeah,
understanding.
yeah, or Dilaudid. It
Or
depends. I mean,
Dilaudid.
so if you look at the actual opioid receptor binding affinity, the strength that it binds to those pain receptors, the mu opioid receptor, Dilaudid is going to have a little bit better binding affinity. It's not as potent, right? So you're not going to. Fentanyl is a more potent drug, but it doesn't have the same binding affinity as Dilaudid. Now, buprenorphine has the highest binding affinity. Other than there are a few fentanyl analogs that can, and then we don't know about some other drugs that are currently potentially in the illicit market that may have stronger binding. But buprenorphine, in terms of the drugs that are generally out there, has the strongest binding affinity to mu receptors, and so that that is why if you are on buprenorphine or Suboxone, buprenorphine being the active drug in Suboxone, that is important to potentially have a plan as a surgeon, as an anesthesiologist, of how you're going to manage somebody, especially when they're on high dose buprenorphine. And I personally end up, I have a lot of patients who are in my clinic who have opioid use disorder and are on buprenorphine who have to have surgery. A lot of them started with acute or chronic pain and end up developing opioid use disorder. They end up in my clinic. Well, those people still, like, they may have chronic pain from like they need their hips replaced. For example, I've talked to a lot of orthopedic surgeons and oral surgeons, because people still need to have surgery. They need to get those pain causing etiologies managed. And so I will just, I've had conversations with surgeons where they're like, I just am uncomfortable with this, and I'll explain my plan. So what we often do, and we do this on our inpatient consult service too, is we'll bring people down on their overall buprenorphine dose and give them short acting opioids for the duration of time in their perioperative period, and then they can just go back up on buprenorphine eventually when they're feeling recovered. Now, there are some patients who truly don't want to be given short-acting opioids. They feel very triggered by that. And we always want to respect patients' autonomy in those decisions. And so, yes, in the hospital setting, we're like, great, let's just keep on going with sort of as needed pain dose ketamine, for example, and use those adjuncts. But if they're open to short-acting opioids, then we'll use those as a bridge and bring their buprenorphine down. The general recommendations are, if they're, say, higher than 16 milligrams, bring them down to 16 milligrams, because that gives you enough room in terms of the amount of opioid receptors left in their body to fill the rest with a full agonist. And that the idea is you don't want to take somebody completely off of their buprenorphine, and that will allow you to still ramp them up and give them better pain control. So I can bring people down. Again, it's sort of meeting people where they are. If I've gone down to 16 and they can't get enough pain control, we'll still keep going down on the buprenorphine. But yeah, you want to fill those receptors and still use things like you said, like Dilaudid and oxycodone.
Yeah, because no patient should have to suffer. I mean, you just had surgery. It's just
Yeah.
and I think this kind of leads into a great thing that we kind of talked about earlier
Yeah.
before
Yeah.
we went live is Suboxone versus just like Subutex. So straight
Yeah.
buprenorphine versus buprenorphine and naloxone, right?
And this is my favorite topic, because I also really love sort of debunking misinformation, and this is a pure marketing play by the makers of Suboxone in convincing the entire healthcare apparatus that naloxone was going to be the secret to treating patients with opioid use disorder with buprenorphine. So the Data 2000 legislation was passed in 2000, the Drug Abuse Treatment Act, which allowed for the prescribing of buprenorphine for people with opioid use disorder. Prior to that, it was only for pain management. It was not legally allowed to be prescribed to people with opioid use disorder. And you had to get a specific, what's called the X waiver on your DEA license at that point. Now, you could prescribe for acute or chronic pain as long as that was the reason you were prescribing. You didn't have to have an X waiver. Only if you were prescribing for a patient with opioid use disorder. And so now all of a sudden, here's a marketing opportunity. Oh, you're going to be treating patients with opioid use disorder with a long-acting partial agonist opioid, but an opioid no less. So they were saying, oh, well, we're going to create an abuse deterrent that's going to help prevent overdoses. And if you actually look at what is functional in buprenorphine, and there's a paper, and I will provide it to Brandy to put in the show notes, but they actually toxicologists looked at this and they said, look, buprenorphine has the stronger binding affinity between buprenorphine and naloxone. Buprenorphine binds the most strongly, more so than naloxone. The half-life of buprenorphine, when taken sublingually, and it varies based on absorption and metabolism, but is between 17 and 30 hours essentially on average, right? So you're talking about a really long-acting opioid that binds really strongly. Now, naloxone is much more short-acting. When taken sublingually, it's in the matter of hours. Like, it will be out of your system before the buprenorphine is out of your system, and it doesn't bind nearly as strongly as buprenorphine. So the hypothesis of this paper is that buprenorphine then is the only functional medication or drug within Suboxone, and naloxone is functionally inert. And so then they tested this theory, and they demonstrated that indeed buprenorphine is the only actual functionally active medication or drug in Suboxone. So really, there is no reason to include naloxone with buprenorphine for the treatment of opioid use disorder. You can use pure buprenorphine and it is not going to change outcomes. The other thing about that is that when people talk about what is precipitating withdrawal, when people use Suboxone, they think it's because it has naloxone in it. And that's also incorrect because buprenorphine binds more strongly than the naloxone that's in it. So buprenorphine is the thing.
I thought that. And
Well,
so, because that's what you're taught. That's like basic, like, just kind of what's told to us who don't actually work with these drugs on a regular basis.
Yes, exactly. And so, and I tell this to other doctors all the time, like other clinicians, like it doesn't matter if it has the naloxone in it because the naloxone isn't what's precipitating withdrawal and it's not the effective treatment. It doesn't need to be included. The only reason that I prescribe Suboxone is because it's the only formulation that comes in strip form, and the strips dissolve faster and they don't taste as bad and they can be cut up easier for variable dosing. And so some people like that better. And if it is the patient's preference, I will gladly go with that option. But otherwise, it comes in plain tablets and plain buprenorphine. And that is no longer restricted because in California, because we're actually following the science here, but it is still in some places. Some pharmacies will not dispense non-Suboxone, non-buprenorphine naloxone combination drugs if they don't have what is considered a valid reason, which is pregnancy or an allergy. And ACOG, the American Congress of Obstetricians and Gynecologists, issued a statement, I think in 2017, saying that buprenorphine naloxone and buprenorphine alone show no difference in outcomes in terms of pregnancy, in terms of harms to fetus. So no increase in fetal anomalies, no other changes in like the neonatal abstinence syndrome. And so the thought then in the statement that they issued is like, if somebody is already on buprenorphine naloxone, there is no harm in continuing them on that. There's also no reason not to change somebody over to plain buprenorphine in my mind. But if that's what their preference is, that there's no change in outcomes and that like abides by ACOG guidelines.
Well, my daughter's pregnant and she is, well, I mean, I'm not going to tell the whole story here, but she was on Suboxone, but had to get on Subutex because she actually had anaphylaxis from it. Taylor, you know this. So it's, and so that was it. And then not long after she ended up getting pregnant. And so, but it's really a pain in the butt. And what the hoops I had to jump through with the pharmacy, because she had been prescribed a month's supply of Suboxone, to then needing to switch her to Subutex when literally, like, I thought she was going to die in front of me. She has an EpiPen.
I mean, that sounds terrifying.
And
that sounds so scary.
And them, me telling them that, you're going to force me to have to give her this with Benadryl and her EpiPen available. Like, and they didn't care. Corporate cared when I complained, but it was, but they called me real quick the next day and it got rectified. But it is hard. It's a shame when people have to jump through those hoops just to get Subutex, and and she now has to be on it, and because of this allergy, and people don't want to prescribe it.
Well, and the other thing too is it is more expensive, right? The combination formulation is more expensive than the plain buprenorphine tablets. And so that is, in my mind, another perfectly valid reason to use a thing that works perfectly well and is cheaper.
Yes. Now, I don't know the answer to this. I suppose you can answer this. Is people seem to think that injecting Suboxone, they're not going to get high from it if they inject it, but they'll get high from Subutex. Is that true? It's like the same. It shouldn't really make a difference.
It should have the same effect. It would all be based on the amount of buprenorphine in that syringe and their level of opioid tolerance prior to taking it. Because if their opioid tolerance is already really high, I'll tell you what, it's not going to give you the effect.
And there's a ceiling. People don't realize, like Suboxone, like buprenorphine, there is a ceiling effect where and because I've talked to pharmacists I work with about that, and that people don't realize.
And so this is the important thing to understand when we say it's a partial agonist, and it's hard to explain because there's a binding curve, right? And so it is more closely aligned to acting as a full agonist at lower doses, and the higher you go, the less of a full effect it'll have. It's that partial agonism, but on average, we say it's approximately 50%. It's half as active as another full agonist. And so because you hit that 50%, right, and you got that like asymptotic growth curve as it's approaching 50%, as you're getting like infinitesimally smaller changes, it does hit that kind of ceiling at a certain point. And what we find is that your respiratory drive is driven by your midbrain. The fact that you have that ceiling effect at that sort of 50% level is not high enough for people to overdose. It's not. So that's not the naloxone that's in it. That's the actual properties of buprenorphine, that you hit this ceiling and you aren't going to get further respiratory depression. Now, can people slow down their breathing? Of course. Is it going to kill somebody? there are only very, very few, very rare reports of just buprenorphine alone being in somebody's system who has overdosed. Is it possible? I don't want to say it's impossible because lots
You
of
could
things
die
are
from
possible.
anything.
Right. And what you learn in medicine is that nothing is 100% or 0%. Nothing's black and white. So I don't want to say anything definitively 100% it's not possible, but it is very, very difficult for a full-size adult human, even without an opioid tolerance, to overdose and die on buprenorphine. The deaths that they have tracked are often will have buprenorphine and other substances in their system, that other substances that cause respiratory depression. So those risks are things like benzodiazepines, alcohol, other GABAergic substances, including gabapentin. So GABA is the thing that alcohol and benzodiazepines activate, which can also decrease your respiratory drive when in combination with something like buprenorphine. So those are often the biggest other substances. And then, of course, like fentanyl and other opioids can also be found in somebody's system that has overdosed, including buprenorphine. We call those buprenorphine involved overdose deaths. And there was actually a recent paper that reviewed like a large number of these buprenorphine involved overdose deaths. And the recent paper, I don't believe it had any in that paper. There's a prior review that I looked up that had like 3 out of a huge sample population. I mean, huge being relative, hundreds and hundreds. And there were only 3 plain buprenorphine only involved in their system that they were able to detect.
Nice. And then it kind of bringing up, as far as I told you earlier, how I have had people tell me that they've been like 10 days off of their drug of choice, usually fentanyl.
Sure.
That's usually, and they're like, they're in horrible withdrawal, and every time they try to take their sub, they say it puts them into precipitated withdrawal. And we were kind of joking about this before we went live, you guys, and just in that we were wondering if it just feels like 10 days, but maybe it's only been a couple of days. There's many factors, so I'll let kind of Taylor answer this.
Yeah. I imagine when you're in withdrawal, 1 day feels like 100. And so I don't know what 10 days looks like in terms of actually being 10 days. It would be very unlikely so the reason fentanyl has changed the game in terms of buprenorphine initiations is that it is very, what we call lipophilic, and it is highly potent. So the drug supply used to be predominantly heroin, different forms of heroin based on where it was coming from in different parts of the country. But it was predominantly heroin. And back when I was in training, in residency, it was all heroin. And so heroin is not lipophilic and it's not super highly potent.
And
so once it was,
explain what lipophilic is, because a
yeah,
lot of people aren't going to understand what that is.
Yeah, good point. Thank you for pointing that out. So lipophilic means it is fat soluble. So you absorb it into your fat cells, and then you will gradually release that over time. And so you can utilize the lipophilic properties or the fat soluble properties of certain drugs to make them even longer acting. One example would be diazepam, which is a benzodiazepine that is lipophilic, while the rest are not. And so that can create a longer acting nature for that benzodiazepine. Now, fentanyl is highly lipophilic, which means you store it up in your fat cells. Heroin was not. And so when you were in withdrawal, meant heroin was out of your system and you could just start buprenorphine and you weren't going to precipitate withdrawal. And the reason, again, precipitated withdrawal happens is because the buprenorphine binds more strongly than that full opioid. So you're basically replacing 100% with a half. And if you do that enough times, you're decreasing the activity so quickly that you're going to precipitate withdrawal. Now, what happens a lot of times with fentanyl is that it still takes a few days for all of it to come out of your fat cells and come out of your body to the point that you're low enough in your fentanyl level in your bloodstream that buprenorphine, an initiation of buprenorphine, isn't going to kick off enough full opioid agonists for it to drop that level super quickly. Even if you still had a low level in your bloodstream, you have a lot of opioid receptors left that buprenorphine can occupy. So a lot of times what happens is that people are already in withdrawal and they're on this withdrawal curve, right? The fentanyl's starting to come out of their system. It's a very short acting drug in general. So we don't think of it as like having this long acting tail, but it does because of the highly lipophilic nature. So we have this long acting tail. It takes multiple days for all that fentanyl to come out of your system. And so usually around 3, maybe 4 days, you really are pushing the limits of when you can actually precipitate withdrawal. What is usually the case is that you're still in free fall on this curve of like not having fentanyl in your system or not having enough, and you're just still experiencing withdrawal and you're taking too low of a dose of buprenorphine for it to pull you out of withdrawal. And so you're just you like bound a couple opioid receptors, but it's not enough to pull you out of this free fall. So often the case, and when I've seen or heard people tell me this, it's because they've been prescribed a microdose taper, and that often starts with like half of a milligram and then a milligram, and often people will do it over multiple days. And so they're taking half a milligram 10 days in, and they're like, it didn't work. And it's not that it precipitated withdrawal. You're just still in withdrawal because that wasn't enough to get you out. If you're at the 10-day mark, just go all in, and that will pull you out. You shouldn't be able to actually precipitate withdrawal. You should just be able to pull yourself out by taking enough buprenorphine. And so that's what I often do with patients when, they can tolerate. I actually had a patient recently who like came into clinic. We take walk-ins. He was a walk-in. Said he was 5 days out. And I was like, are you really sure that it's been 5 days? Because if it has, I can just give you 16 milligrams right now and we'll get you out of withdrawal. But if it hasn't, then there's a risk of precipitating withdrawal. And he double checked, and it had only been a day and a half. And so I would have risked precipitating withdrawal in that case. And I imagine, I was like, I don't blame you at all. I imagine it's felt like an eternity. But like, let's wait on starting. And if people can make it out of that withdrawal period for a few days, that is an opportunity to just do a start at 3 to 4 days in from your last use. The other method, and what I think some people might be talking about here, Brandy, is what we call the Bernese method, which I didn't know where the name came from until I read the original paper that described the Bernese method, which came out of Bern, Switzerland, which is why it's called the Bernese method. So,
I didn't know that.
yeah. That one was confusing for me at first. I was like, I'm not sure where this comes from. But so the idea is that you can use both fentanyl and buprenorphine in the same day and gradually take low dose buprenorphine and build that up in your system over time, over the course of a week, 10 days, whatever. And so again, starting with half a milligram, and then also, so you take your buprenorphine and then you can continue to use fentanyl after that. It's bound to those receptors already. The fentanyl is not going to kick it off. And then you can use fentanyl to make sure you're not in withdrawal. And then you increase the dose the next day, and then you use fentanyl, and it'll fill up the rest of those receptors. And then the same thing the next day and the next day and the next day until you hit the point where you're not feeling the effects of the fentanyl that you're using. Then you've hit your threshold. That's where you're at your point where there's enough buprenorphine in your system that you're not needing fentanyl. You're not getting any effect from the fentanyl anymore, and you don't need any more fentanyl to get yourself out of withdrawal. So that is an option for tapering. So if people are struggling with that process, that's, again, one of the ways that we do initiations of treatment.
Yes, and the Bernese method, actually, how I heard about it was this is how people will transition from methadone to Suboxone. Like, 'cause this is something that's commonly used when people want to go into, which will bridge right into this, Sublicade, Brixadi, when they're wanting to transition to the monthly injection. And I'll let you explain exactly what that is.
Yeah. So Brixadi and Sublicade are both long-acting or extended-release buprenorphine injections. So they're injectable buprenorphine that goes under your skin, not in your skin, but into the like fat or tissue underneath your skin. Sublicade came out about 7 years ago, and then was given an orphan status, which meant that they had exclusive rights to market their drug. And that was fought in court because Brixadi came out or was created subsequent to that. So they did their research in 2014, their initial research. And so shortly after Sublicade came out and was granted orphan status, the makers of Brixadi, which are Braeburn, is the company, took them to court and eventually won. And that's why instead of being 10 years, they were able to come to market at 6 years. And so it came out last year. Came out last summer, almost exactly a year ago, I want to say. And so both of them are different versions of long-acting injectable buprenorphine. Now, Sublicade works by creating this gel matrix. And if you've seen it, it's like thick like molasses. And it creates this gel matrix when it hits your tissue under your skin. It creates this little like nodule. And that's, some patients don't like that. But so it comes in 300 milligrams and 100 milligram doses. And that it doesn't have an exact dose matching. But the idea is you get an initiation of that Sublicade treatment on the 300 milligram dose, which is usually approximately 24 milligrams equivalent based on anecdotal experience. You can get to higher levels, but and then that keeps a consistent level over time in your bloodstream as your body breaks down this gel matrix that exists in your abdomen. And now that's the only place that on the package insert that you're allowed to do the injections. That's the only place that was FDA approved. And then that breaks down over the course of a month. So they're month-long. That's a month-long injection. Like I said, with 2 doses, and people use that to taper off too. And because it's so long, again, that half-life being the duration of time that something exists with the equivalent circulating effective dose in your system is a month. And so we say it takes about 4 to 5 half-lives for something to be out of your system. So we're talking about like 4 to 5 months and potentially longer, depending on your metabolism, et cetera, for that Sublicade injection to be out of your system. Brixadi, the one that's newer, more recent, it is a much smaller volume. So Sublicade is 100 milligrams per 0.5 mLs. So the 300 is 1.5 mLs. That's actually a decent amount. If you like don't have an estimate, that would hurt in terms of tissue displacement. The amount of tissue you're having to move to fit that in. Brixadi is the high. It differs based on the dose, but the highest dose is 0.37 mLs, and that highest dose is 128 milligrams, and they do have a dose matching chart. And so that's supposed to be approximately 24 milligrams of sublingual buprenorphine equivalent. And then 96 milligrams is the next dose down, and that is, again, a smaller volume, and it's approximately 16 milligrams, and then the next dose down from that is 64, and that's approximately 8 milligrams per day. This is per day sublingual dosing, by the way. And it lasts also for a month. It's FDA approved for up to 5 weeks.
Subcutaneous.
So it's also
Or
subcutaneous.
do they give Brixadi
No.
sublingual?
Sorry. I mean equivalent
To
8
the
milligrams,
Suboxone.
16, and of Suboxone dosing, of sublingual dosing, but it is given subcutaneously. And so Brixadi is approved per the package insert to administer in the upper arm, kind of like a vaccine. It kind of looks like it's preloaded with a small needle, and it's a small quantity. You can inject it in the arm, kind of like a vaccine, in the abdomen, in the thigh, and in your butt. So there's a little bit more, there are a few more places that you can give it. It doesn't leave this gel nodule behind. It is a extended release. Like my understanding is it's like a nanoparticle released buprenorphine. So it is extended. It just sort of trickles in over time. And And like I said, it has that dose matching. They also make monthly and weekly injections. And the weekly injections, they have the 24 milligram sublingual equivalent, 16, 8, and then less than 8. And that's the only one that where you can go less than 8 is in a weekly dosing. And so you can use either of those to taper. And again, because they have that really long half-life and keep that sort of consistent level over time, people are finding those are both really useful for tapering off.
And I think it's important to mention that Brixadi is cheaper than
Yeah.
Sublicade.
Yeah.
And
If you were to cash pay for it, Sublicade is about equivalent between the doses in terms of the cost, and it depends obviously like what your insurance covers. And Brixadi is sort of more expensive, or the cost is adjusted by the dosing, whether it's monthly or weekly, and then the actual dosage that's included in that. So it's slightly more expensive to get the slightly higher dose than it is to get the lower dose.
And I think, because of my experience, some states, I know California is really progressive. And as far as even what like their state, like their Medicaid covers, I believe they'll cover Sublicade, is my understanding.
Medicaid covers both. Medicaid
Really?
covers both the buprenorphine naloxone combination sublingual and plain buprenorphine tablets, and we don't have to write a rationale as to why we want the plain tablets, and we'll cover Brixadi or Sublicade. So patients who have Medicaid have their preference of either one. And a lot of insurance companies are starting to come around to this idea. A lot of them already covered Sublicade, and then Brixadi's kind of newer. So I've talked to pharmaceutical companies, I've talked to insurance companies about coverage for pharmaceuticals like Brixadi, and I'll have been met with questions a number of times about like, I don't know what drug you're talking about, because it's newer. And so when people start demanding it, they will probably be more likely to cover it.
So in Florida, good old Florida here, is Medicaid will cover Vivitrol. That's my understanding. That's about it. They'll cover Vivitrol, and they will not cover Sublicade. And let me tell you, so my daughter goes to a provider that actually, it was through my social media that I found out about this provider that did Sublicade, and they said they would deal with insurance to get it approved. But then my daughter got pregnant, so she can't do Sublicade right now. But we've just continued to have her go to that provider because she does want to transition to Sublicade after. That's just what her choice is. But I started looking when we talked about Brixadi, and you were telling me it was more affordable. I can't even find a provider that does Brixadi in Florida.
Oh, no. Why?
And that office that she goes to that does Sublicade, they had never even heard of it.
For the providers out there who might be willing to do Brixadi injections, I will say this: it's not only cheaper, it comes in a pre-filled syringe with the needle already on. It's a 23 gauge needle. It's smaller. It is much easier to use, and it doesn't require refrigeration. Sublicade does require refrigeration. They recently extended that. They applied to change the FDA approved period that it can go without refrigeration to 12 days. But unless you're like getting it in and having the patient come in right away, it still requires refrigeration. So you still have to get a special fridge that has a lock that is secured. Brixadi, you simply don't, and it can be administered per the package insert by any healthcare provider. So that's not the same as Sublicade. So it can be easier on your workflow too, if that's something that you're interested in. I'm happy to talk to anybody who would be interested in doing it, because and I receive $0 from really any pharmaceutical company, just to make that very clear. You can look me up. It's called the Sunshine Act. It's www.openpayments.cms.gov. You can look up any amount of monetary value that is given to any physician in the country. I will readily admit that I looked myself up the other day, and I was very disappointed that I have received $23 total worth of monetary value from a breakfast that I received for a board meeting one time last year. But otherwise, I don't receive any money from the makers of Sublicade or Brixadi, but I do personally feel strongly that people should be given those options. One, out of my belief in respect for patient autonomy, and that is a treatment option that is very much valid, that is evidence-based, and that people are having very good success with in terms of tapering off. And so that is something we should offer for that reason. And also because I want to see people succeed, and that this is a really effective treatment option, even for patients in ongoing treatment, because they just don't want to have to think about taking something every day. And it's super easy to just give them an injection.
Absolutely. And I will tag her profile in the show notes on here, but Marie on TikTok in particular, she was on Suboxone, I believe for 8 years, she said, and she has documented her journey of when she transitioned like to Sublicade. And I can't remember how long she had been on Sublicade, but she's completely off everything. And she even shared when she it was almost a year later when she finally had a negative drug test. From the buprenorphine that was in the Sublicade. And so, but you guys, what's nice about this, so many people fear withdrawal, and it's, you can pretty much get off of Suboxone almost virtually withdrawal free. Like there's options. We didn't have these options before. So when you have people that say, oh, it's worse to get off than fentanyl, than heroin, it really, it's like, we'll talk like the half-life is longer. You're just going to be in withdrawal longer. So yeah, it's going to feel like pure fucking hell. But we have medications to help you get off of it completely, almost completely withdrawal free. Many have said withdrawal free. I think you can agree with that.
Yeah. And so to speak exactly to that point, withdrawal is going to be equal and opposite to the effect of the drug, right? So if you're withdrawing from fentanyl, super high peak, really potent, really short half-life. So your withdrawal is going to be really miserable and for a shorter period of time. You take Suboxone, you take fentanyl, and you take the same curve of opioid activity, you just stretch it out to 30 hours instead of 2, and you're talking about, and cut it in half because it's a partial agonist, but you're going to have a less severe, less miserable, but for a prolonged period of time. And also, that's dose dependent, right? So if you have a ton of opioid receptors that are activated, whether it's with fentanyl or buprenorphine, you're going to have a stronger withdrawal period or a stronger withdrawal effect. And so the same is true with stimulants. Your stimulant withdrawal period is the crash that happens afterwards when you don't have a stimulant. So it's equal and opposite. And so when you're talking about something like Sublicade, where you have this really long half-life, and you look at Marie's and like it took a year, that means it took literally a year to go from this effective circulating dose at, I think she was using the 300, and then to all the way off. It's just such a long tail that if you look at what the area under that curve is, what the equal and opposite effect of that drug is it's going to be just about negligible, because that long tail made the effect feel to her just about negligible. And so I remember the first, and I don't always follow up on all of the patients that I've tapered off. I taper off patients from our clinic all the time. The first patient that I was able to taper off with Sublicade, he came in about 4 months, 5 months, maybe 5 months later after his last injection. He got a couple injections, and then he came in and he's like, I haven't been able to sleep for a few days. And he's like, I don't feel anything else. I don't have nausea, chills, I feel just like restless in my brain and I can't sleep. And he's like, I made the connection potentially to the Sublicade that I got. And I'm wondering, because this feels kind of like the most minor withdrawal I've ever had. Is it reasonable that could be withdrawal? And I was like, that is not only reasonable, that is literally a perfect description of like pharmacologically how this worked. You have now hit the point, probably just now, where the Sublicade is completely out of your system, or it's at a low enough level where you just have the most mild withdrawal. And so we can manage that just like we can manage any other withdrawal for people who are tapering or are currently in withdrawal, depending on how they want to manage their own withdrawal. Is we can use medications like clonidine, like hydroxyzine, like baclofen, like Zofran, depending on the symptom, right? We're trying to treat the symptoms of the withdrawal. And in this case, it was restlessness and anxiety. A little bit of clonidine, a little bit of hydroxyzine, both helpful for sleep. Clonidine alpha-2 agonist, you're blocking that adrenaline type response you get from withdrawal. Hydroxyzine is an antihistamine that has a lot of more sort of what we call centrally acting, acts more on your brain than the rest of your body, than like Claritin. And both of those, one, help you sleep, and two, decrease your anxiety. And so gave him a little bit of that, and
All
that
better.
was it. All better. All
Yeah.
better. And it was like, it was amazing to me that he recognized that, and he came in, and I was like, oh, I'm so happy to hear from you. I've like haven't had anybody tell me what this felt like once they were actually off. And that was like the perfect description, because that, I think, is kind of exactly what it's like.
Yeah, no, so I take clonidine. I
Yeah.
take that actually for sleep because I have horrible insomnia, and then I have ADHD, and I've been on a stimulant for like 20 years. And it's my dosing doesn't change. It's been the same. I know my body, and my sleep is impacted by that still. And I think I'd have insomnia even without it. But clonidine, nothing else will work. I get that groggy feeling. Clonidine, man, I go to sleep. It works wonders, and it's a great drug. And I didn't understand this, and I guess it's basically works the same way as Precedex, right? Is my understanding?
Yeah. So Precedex is dexmedetomidine, also an alpha-2 agonist. It is an IV drip. It is an IV administered medication that we use in Brandy's very familiar with in the
Alcohol
ICU.
use disorder.
We use for alcohol use disorder. We use for
Anxiety.
agitation. We can manage somebody who is intubated, but continue keeping them awake while they're intubated using things like Precedex. So it's a really cool medication, and it acts sort of in the same way, but in an IV form.
Yeah, which is really cool when I found that out, because I didn't realize they were similar like that. I was like, oh, I use that med all the time. It took one of my attendees telling me that.
Yeah.
But and I guess another thing is you and I both know that unfortunately in this system we have a lot of people that are in it for money, not for helping people, whether or not they started out with good intentions and went down the wrong path. But either way, they've gotten there, because I get a lot of feedback. I'm sure you hear the same, where they're like, they won't even consider doing Sublicade. They won't even consider tapering them. How do you think someone should approach their provider that's prescribing their mat that wants to taper off? Because you know what? Like, I think we support MAT completely, because it is the gold standard treatment, but I fully support people who want to get off of it, right?
Yeah.
Nobody wants to be dependent.
And I ask my patients that every visit: what is your goal? Because my goal is only to meet you where you're at and help you accomplish your goals. And I have a lot of patients who, when they come into treatment, and I ask them that up front, and they're like, nobody's ever asked me that. Like, I've never thought about it. And so if we have that approach of trying to meet people where they're at and help them accomplish their goals, tapering off is a lot of people's goals, and that's a perfectly valid thing to do. They don't have to feel like they're burdened for life with having to take treatment, having to take buprenorphine or methadone, whatever it is. They should use it as long as they need it to feel stable and functional in their life. And that's the entire goal. That is why it is treatment. And so we should be able and willing to taper people off. We should know how to do that effectively, whether it's tapering down doses gradually over time, whether it's administering injectables like Sublicade or Brixadi. And we should be doing that when people are ready to do that. So in terms of approaching somebody, I would say when you are looking for a clinic, like, ask them if they taper people off. And if they don't, I mean, it's also fine to get started. If there's a clinic, like, you just need to get in treatment and you need to get stable, great, do that. But when you have the opportunity to go look for a clinic that will provide this care for you, find a clinician who is willing to taper you down, who has a safe, ethical way of treating you, of tapering you down, of getting you off, of giving Sublicade or Brixadi or both, or that they use both in their clinic. And these all, by the way, can be utilized in primary care. You don't need any additional licensing. You can just prescribe it. If you have a DEA license, you can prescribe buprenorphine. If you have a DEA license and you have a REMS provider, which is a barrier in terms of getting Sublicade and Brixadi, but if you have a REMS provider for your primary care clinic at all, you can get Sublicade or Brixadi in your clinic. And I am our REMS provider for our clinic. It's easy to do online. You're just registering essentially as you're registering your address, and you're registering yourself in that monitoring system. And so it's not a huge barrier. If you wanted to do that for your clinic, if you didn't have a REMS provider, you could easily do that online too. And then you can order that, and you can provide this care to patients who need it. So I would say, one, if you're on the clinician side, anyone can do this, and this isn't super difficult. And frankly, Brixadi makes it easier, because it's literally, if you can give a vaccine injection, you can give Brixadi. And then if you are a patient looking for this, when you are stable, ask them if they taper people, how they get people off. And if they do, injectable extended release buprenorphine, and go look until you find a place that does that, because that means that those are ethical providers who are trying to meet you where you are and accomplish your goals with you.
And I guess we'll kind of wrap it up, but I'm curious as to what would you tell families, parents, whatnot, anybody who has a loved one that's dealing with substance use disorder, because I think a lot of people, what is the main meeting that's pushed? It's Al-Anon. That's really like about all there is. And it's, that's very much 12-step based, and kind of pushes the tough love narrative, and very anti-medicated assisted treatment. What would you say to families about medicated assisted treatment?
I have a lot of families who bring patients in, and my goal is never to invalidate their experiences, and they can, I understand they can be harmful, they can be really negative, they can have trauma from their son, daughter, spouse in active use, and that's real, and I can acknowledge that, while also saying this is treatment, this is life-saving treatment that is important. And I've had family members ask me, like, when do they get off? I say, that's not for you or me to decide. That's for them to decide. And they could decide in a few months, they could decide in a few years, they could decide that they never want to. And all of those are totally okay, as long as we have an informed discussion about, what that will look like for them, then that's fine. But I think it's important to emphasize that, if you are a person who is actively using opioids, that this is not just to manage detox or withdrawal. This is treatment. And just like I would want them to get treatment for any other medical condition, this is a medical condition of theirs that I want to treat, that I've been trained to treat, and that I know how to do in an ethical and effective way. And I think people are generally pretty receptive to that. I think people still carry a lot of pain and stigma, even around having their own, as having their own son, daughter, family member who's in active use. And so it's a lot of unlearning, and it's not going to happen quickly. And there aren't good meetings for family members. And the thing that I try to emphasize to people is that, we don't do enough in terms of discussing the real harms to caregivers. And that's across medicine. That's not just in terms of substance use disorder treatment. That's everything, right? You see it in the ICU all the time. We have family members who are, devastated, and maybe have life-changing experiences where now they have to be the care provider to somebody else for the rest of their life. And we don't talk enough about what that looks like in terms of the impact and the harm that that can have on the people in their lives who are in those circumstances. And so I will tell people, like, all the same as I want to acknowledge and support this person and their autonomy in treating them for their use, I want to acknowledge and support that family member for what they are experiencing and what they have experienced. And that's an important thing, that like, we have counselors, we have a psychiatrist in our clinic. Like, our counselor, we have a counselor who has a history of her own substance use disorder and can speak to that very well. And she's a credentialed counselor, and can speak to what it's like to be a family member, because she also has that lived experience as well. And so we have people who are patients in our clinic who like will meet with their family members too, or we'll do family sessions together. So and I try to emphasize that to family members, because that part can be really hard, and I don't want them to feel ignored or dismissed by that. But it is. I mean, there aren't. I struggle with the idea of people going to Al-Anon, because I know how negatively that affects people in terms of having a stigmatized abstinence only mindset. And so it is an option. I don't diminish that if people find that support helpful, but I don't ever actually suggest that to people.
So you know what's funny is I didn't talk about it on your podcast, and
Yeah.
is I had written, because people kept asking me, they didn't want to go through all my videos, is I made like a guidebook of when
Yeah.
Brooke, I think before she even came home to get sober, and I laid out just like literally 1 through maybe 10 or 15 of what not to fucking do, basically. Like, stop talking about rehab. They know you want them to go to rehab. It's give them money, don't give them money. It's your fucking choice. Like, literally, I think I even use, me and my foul mouth. The whole, it's all in the book. But
It's great.
but it's true though, because, but still, even me, I'll tell people when they message me, what should I do? They've never even heard of Al-Anon. And that baffles me. I think because my mom was, she has alcohol
Right.
use disorder. So I knew what Al-Anon was because of that. And
Well, and you and I share that in
I
common.
know.
Like, I knew about Al-Anon
And
as a kid.
you don't know what Al-Anon is? I mean, I knew for out of diapers, but still, like, I knew about it. And so, and I'll say, because there's really nowhere else to refer people. And I'll say, listen, I don't go to those meetings. I don't agree with those views, but you can find them in almost any community. And
Mm-hmm.
these people need support, and not
Mm-hmm.
everybody is like us. Like me, I
Right.
found my support talking on social media. That was
Yeah.
my therapy, and it was wonderful for me. And but not everybody
And it
can handle
changed
that.
you.
It did, for the better.
I mean,
For the
in
better.
in a like and you and I have talked about this before, but I think it was a very like unique view into the process of like unlearning.
Hmm.
I thought, I mean, I think it's exceptional, and anybody who is a family member who is looking to better understand, like, I would highly suggest watching Brandy's videos. I know I'm on your podcast, so I'm preaching to the choir, but but I think I think it was really fascinating to watch. And I think it's a useful place that people can learn from for themselves, because they may have started in the same place that you started, and then
Yep.
they can see that change and see that now your daughter is
Sober.
thriving.
Yeah, like she's almost 8 months sober, and that's the longest she's ever been sober. And she skipped out on the norm. She didn't go to treatment. She didn't go to detox. And not saying I recommend that for everyone. I think detox has its place. I'm a medical provider, and I was with her, so I know things to look for. Not everybody is going to be able to do that or handle that. But so I was in a very good place to do that. But yeah, we didn't. And this is like the longest, because she would relapse within a month of coming home after a
Mm-hmm.
treatment, every
Yeah.
time within a month.
And if you give people a modality that doesn't work for them over and over and over again, it's still not going to work for them.
The
So
definition of
now,
insanity.
yeah. So now, actually, I should just refer families to go watch all of your videos.
No, I know. Like it's crazy. And I'll say when you get the on this day videos and they come up and I'm like, oh, I cringe, but I share them because it
Yeah.
just does show that, and a lot of people don't even recognize me.
Hmm.
And I'm like, no, that's me. And that's how I would talk
Hmm.
then. And in that you
Hmm.
can change for the better,
Hmm.
for
Yeah,
sure.
absolutely.
But
Absolutely.
well, thanks for coming on. And I guess where can people find you? I'm going to tag it all in the show notes, but
I am on TikTok at tnicholsmd. I have a website, tnicholsmd.com. That's usually the easiest place it has my email. You can just contact me that way. But yeah, on social media, find me on TikTok. I'm also on Blue Sky at tnicholsmd as well.
okay, great. And recovery reform
Oh yeah, I should plug
I
the
should totally
podcast.
plug the podcast.
Sorry, Macaulay. I have a podcast that I do with Macaulay Sexton, who is a person with lived experience. It's called Recovery Reform. It's about sort of navigating the world of harm reduction, health policy, and sort of drug policy reform.
All right. Okay, everybody. I'll tag everything in the show notes. Taylor, thanks for coming on. I'm so glad we were
Thank you,
able to do
Brandy.
this. And until next time. All right.